to another insightful episode of MedSynapse podcast series. I'm your host Hetvi Shah, and today we are diving into a topic that is transforming the way we manage pain, which is interventional radiology in pain management. Chronic pain is a debilitating condition affecting millions worldwide. And while conventional treatments offer relief, they often fall short for many patients. This is where interventional radiology is making groundbreaking advances, offering minimally invasive solutions that target pain at its source. And to help us decode this evolving field, we have with us a renowned expert in the field, Dr. Avinash Malla. Dr. Avinash is a distinguished interventional radiologist in Chennai in India. With over a decade of experience, he has been pioneering minimally invasive procedures that are revolutionizing patient care. In addition to his clinical practice, he serves as a council member of the junior wing of Indian Society of Vascular and Interventional Radiology, mentoring young radiologists and shaping the future of this field. So, Dr. Avinash, it is an absolute pleasure to have you with us, and thank you for joining us today.
Thank you for inviting me for the talk. You see, IR is very less known to people for a very long time. So with this video, I think more people will become aware of it. And thanks to you, thanks to the team at MedSynapse that, I get this opportunity to talk about it. Yeah.
Thank you, and we're so excited to hear your thoughts on IR, Doctor. Let's start with the big picture. Chronic pain affects millions worldwide. So, how significant is the contribution of IR in addressing pain that is otherwise difficult to manage with conventional treatments?
Pain is the first thing that happens. Any patient or any person goes to a doctor or seeks medical advice when they have pain or fever or something like that. So pain can be an indicator of many things, and many things can cause pain. So what we can do, what intervention radiology can provide information, is that any pain that subsides with conservative management can be left out, right? Those patients who are suffering from cancer, and long-term diseases like osteoarthritis, those patients have very less chance of, completely stopping the pain. They do maintain on a day-to-day basis with medications, continuous medications, recurrent medications, but the pain still exists and it only increases, right? And for a human body, the medication can only be adjusted to a certain dosage. You can give more and more medication for a very long time. So in that particular cases, like cancer patients and osteoarthritis patients and other patients, those who have nerve impingement, they can have better relief from our procedure. The idea of this works in multiple ways, right? We just don't. There are multiple ways we can help patients in intervention radiology. It can be ablating a nerve, cutting off the nerve so that the signal doesn't go to the brain. But also there is a decrease in the inflammation. This embolization can help in reducing the pain and help them day-to-day activities which they are very tough to do on their own with the pain. So we reduce the pain for them to do those activities, and then the quality of life gets better.
True, definitely. And I think it is clear that interventional radiology actually offers hope to patients who are actually suffering from pain from a very long period also. Now, Doctor, when we think about pain management, it is not just one condition. It spans across multiple specialties also, as you also mentioned previously. So that actually brings me to the next question: is what are some of the most common pain related conditions where interventional radiology techniques are particularly effective?
So as I mentioned, osteoarthritis, something that can happen to anybody, and most of the people have it. It's a long standing pain. It starts, early stage, and over a period of time, over a decade of time, the pain increases. It's because of the changes that happens in the joint. So what we can do in this particular case is embolization as such. And also in patients like cancer patients, pancreatic cancer in particular, there's something called celiac plexus block. In this, what we do is we take out the nerves. We just basically kill the nerves that carries the pain signal. The disease as such is been treated by the medical oncologists, and in particular cases, they go for surgery, but not in case of pancreatic. But other cases, and there are lung cancers, breast cancers, they have a tendency to metastasize. It's like spread to the bone. They have a lot of pain. So those things we can treat. And this is mostly minimally invasive. We don't cut open. It's all pinhole procedures. Uh, we have our own, discussions with tumor boards and other doctors to see whether this can benefit or not.
Yeah, actually, it is more impressive to learn about minimally invasive nature, like how it actually just without opening it helps the pain also.
The sports as well.
Yeah.
In sports, those who are very active in sports, athletes and all, they have tennis elbows and epicondylitis and plantar fasciitis. These can also be treated by IR procedures, which doesn't require a long-term medication. You just need a little bit of physical therapy and art treatment, and in a few months of time they are good to go.
It actually also reduces the time to recover also.
Exactly.
Yeah.
There's no cutting open. There is no cut open. You're not disturbing any anatomical structures.
Yeah,
So
that's the
the
most
recovery
impressive
becomes
part.
recovery becomes very fast.
True. So that actually leads to my next question, that could you walk us through some of the most effective minimally invasive techniques used in pain management, such as nerve blocks or vertebroplasty or radiofrequency ablation?
Yes. So these are those what you have mentioned is only like an out frame of everything. So it depends. It has to be tailored on each patient and what they have, what the problem they have. So it's absolutely important that we and the clinician, whoever is treating that particular patient, discuss the particular scenario, right? For example, you take osteoarthritis. So there is something called TKR. TKR is total knee replacement. That's a surgery done by an orthopedician. So for every patient, you can't do TKR, right? So for old patients, there are multiple comorbidities, and they cannot be taken for general anesthesia and all. And some people are not willing for the surgery. For them, and some people are too young for the knee replacement. Knee replacement helps, like it completely takes out the joint and reduces the pain. The overall functionality gets better, but not everybody is fit for TKR. So what we do, and not everybody is fit, as I told you, the other thing. So what we do is we do something called genicular artery embolization. So in osteoarthritis, the synovium, the capsule that covers, has inflammation. So the inflammation, that is the reason the patient has so much of pain. And whenever there is an inflammation in the body anywhere, the blood supply increases. So we go inside the artery, like how many of the people know cardiac angio, coronary angio, right? So it's very clear for them. They put a tube inside your artery, go there and do runs, see stenting and all. This is something similar. We go into the artery that supplies the knee, and we go deep inside and release something called particles. So these particles, they'll cut down the small, tiny arteries that are supplying to the inflammation. Once the arterial supply cuts off, the inflammation comes down. Once the inflammation comes down, the patient will have pain feel, which is lesser. And along with that, we do physiotherapy. We ask them to do physiotherapy to strengthen the knee muscles and reduce those things which can cause pain. Absolutely, because the osteoarthritic part is still there. It's the pain that we are addressing, not the particular etiology, the particular entity that is causing it. So we follow it up and then make sure that pain scale comes down so that they can do their regular activities. And for say celiac plexus, I already told you, the pancreatic cancer. So what we do is we do something called neurolysis. We kill the nerves that takes the signal, that takes the pain signal to the brain. So the pain is there, but the patient won't perceive it. That being said, in every case scenario, like for example, in a patient who went through thoracotomy, that's like a chest surgery. So they cut open the chest, they do a surgery and they close off. And then there is a 50 to 60% chances that the patient can feel pain after that. It happens in a strip. So we identify which level is the pain, and we don't just go and kill every nerve we find, right? So we have to check whether that is the thing that is causing the pain. So how we do it is we pinpoint the pain thing, wherever the patient is having the pain, we instill local anesthesia there around the nerve. If the patient says that yes, the pain has come down, that means we have hit the right place. So the next step would be taking the nerve out completely, the cutting off the supply, and so that they won't feel the pain and not much difficulty. So it's as I said, it's like a pinhole procedure. Most of the patients doesn't require general anesthesia for our procedures. They just need mild sedation, or many of the procedures just require local anesthesia, nothing else. And plantar fasciitis is something that, for the foot, they have plantar is like the lower base of the foot, right? And in that
Yes.
place, they will have inflammation. The fascia will have inflammation. So that again, how the genicular artery embolization, as I explained, this one also helps because we reduce the blood supply. It's called angiogenesis, which will come down. And once that comes down, the inflammation settles. Once the inflammation settles, it's a relief to the patient. Yeah.
So, Doctor, I was just curious that are there any specific factors or assessment you consider when determining whether a patient is suitable candidate for these procedures?
Yes, there are. We need to
Yeah.
assess, we need to see the patient, because there are infections, right? The infections, we should not do anything at that point of time. You need to treat the patient. There are blood infections. There might be a site infection. Wherever you have the pain is a site infection. So you need to treat the infection first. If there is no infection, then you can do it. There are patients which have coagulopathies. Our procedures, like we are going into the body is everywhere with blood vessels, arteries, veins, so when we tiny arteries, they don't cause much damage, but then again there is something called coagulopathy, in which a small minor injury that you can I have it, and then it subsides, it settles, a knife cut, you hold it for some time and it just closes off, it just seals off. But for people who have coagulopathy, it doesn't. It just bleeds on. And people who are on aspirin, clopidogrel, blood thinners, those blood thinners, a damage can cause a bleeding and some hematoma. So we need to see these parameters before doing anything. Don't cause harm to the patient. It should not. Whether your procedure helps the patient or not is a secondary question. The first thing is it should not harm your patient. So you should be very careful having a checklist. We have a checklist of things to do and check everything, what is there, what's not, and everything, so that it's safer to take the patient for the procedure. Ours is indeed, intervention radiology has less complications than surgical procedures or anything. But then we are not like 100%. There is some problems as well here. So but it's quite less.
Definitely, it comes with their risks. Yeah, and that was a great advice actually inside. So now, like any other medical procedure, interventional radiology also come with its risk. So I'd love for you to shed some light on what are some of the most common complications associated with interventional radiology in pain management, and how do you ensure the patient safety in such risks?
Okay, so most of our procedures, as I told you, we'll be going inside the body, and most of our procedures are related to artery punctures. We puncture the artery and then go inside, pass a small tube, and then treat. So whenever you puncture an artery, there's a chance of bleeding. So that's like, it's there. That risk is there for everybody. So we'll have to be very careful while entering. And once we are done with the procedure, depending upon what the patient, what kind of consumables we use, we decide on how to treat it, how to get the hemostasis equivalent, how to close it. So that's something that we have to hold the patient's artery, give some pressure for some time, like how you give, or we use a special devices called closure devices. That's like a surgical knot or a clip, which will close the entry point. So that is one of the common complications that can occur because we are entering inside the body. And the second thing is whenever we are closing off an artery, right, for embolization, in terms of embolization, if we talk. So we are trying to inject some particles inside the artery. The target is important. It should not go anywhere else, because those particles can cause something, can close off some other arteries. So the target is important. So we have to check once, twice to see it's our target that is getting blasted, not something else. Anything can go, right? So we make sure to go as close to the problem as possible, and then release the particles from there. So you end up not causing some damage. It's called non-target embolization. So that's something that can happen. And in terms of vertebroplasty and kyphoplasty, you're mentioning that we do in normal vertebral fractures, single fractures, which can cause a lot of pain to the patient, and also for metastasis. We use something called cement. Everything in the body, the blood enters and blood exits, right? So while injecting those things, we make sure that it should not cross the borders, right? The vertebra has a shape. So our cement should stay in that shape. It should not go out of the body. It should not cause compression on some other things. Just vertebra is also protecting spinal cord, right? So when we are instilling some cement or some causing some manipulating some areas, so it should not go and cause more damage, right? So that is also a risk. But then again, all these risks are like 5%, 4%. It's quite less. But then you don't know for which patient it happens. Now, these are the basic complications that we look into usually while explaining to the patient as well. So we make sure based on the procedure, every procedure has its own set of complications. Like we do RF ablation. RF ablation can cause a little bit of pain, right? So we give particular medication before we prepare the patient that any discomfort. Good thing is this patient is not on general anesthesia most of the times. So they can tell us. It's like they are the best. Exactly. They are the best people to, just let us know if you have any sort of discomfort or pain. So they let us know immediately and we see what's happening or whether it's some pain is expected. So if the patient is bearable, it's a bearable pain, then we give medication and that subsides. So pain is something and the best meter for us is our patient. So they let us know exactly whether the pain is there or not. And again, as I told you, in local anesthesia, we check where we are. It's important that we check every time where we are and what we are doing. So at that point of time in pain management, if you have hit the right spot, we'll wait for 3-4 minutes or 5 minutes, and then we ask the patient, do you feel the pain there? Even by pressing, patient says no. There itself you have your own answer that you're in the right spot.
Correct.
So,
and I think the doctors should be equipped with precision in such procedures because that in itself actually avoids the risks and complications that you would mention. Now, doctor, before we wrap up, one last question is I'd love to hear your thoughts on how healthcare professionals can better integrate IR into mainstream pain management strategies.
IR can help. It's not just pain, it can help in many other ways. So IR is a growing branch now, and it has, for example, I would say for people like for women who has continuous pelvic inflammatory diseases, and it's called, and also pelvic congestion syndrome is what we call. So for those people, they have pain for a very long time, and in the society, they don't just come out right and say, I have pain. They tend to bear it for a very long time. So awareness is important, right? And awareness of patient, awareness of doctors as well. Those who can see, doctors can, as I told you, you can only give a certain amount of dosages and certain amount of medications to the patient. Beyond that, it can cause damage to the patient. So those who know, those who have an idea about how it can help, like in pelvic congestion syndrome, what we can do is the veins get engorged, the veins get very big, and that's the reason why they have very so much of pain. The blood doesn't go up and it just keeps on rotating in that same place. So we do embolization again, ovarian vein or gonadal vein embolization that we do. So for that to happen, now people are also very clever. They open Google, they find out what other treatments are there once a diagnosis has been made. So I think videos like this and more awareness things, so that they can find these videos and they can find out that yes, it's something that can be done by IR. IR can offer a lot of things. So public awareness is one thing that can help IR a lot, and doctors' awareness as well. Those, it is important for us and for the doctors to discuss, right? So anything, not just pain management, any other entity, any other problems, there are experts. There are experts of their own field, medical oncologists or gastroenterologist or orthopedician, whoever it is. Sometimes they, out of the blue, they call and ask, I have this kind of patient. Do you have anything that can help the patient? So in that way, we have more and more CMEs, we have more and more talks in which we can say that this is the thing we can, provide to reduce the problem, or sometimes treat the problem entirely, like in terms of varicose veins or pelvic congestion syndromes. And those patients which have gone through, there are other procedures in which patient requires a long-term management, long-term medication, and you don't have to go through every 3 days, 4 days, you have to change the cannula, the vein, the ventral and the access, right? So we have other things that provides a catheter which can be used for 3 months, or more than that if one. So it's there. We have we can cater, we have more, we have the procedures that can help the patients. It's awareness that, that helps the IR, and in pain management as well, per se. So more and more videos, more and more blogs, and that can help more patients to get find the right, at the best, if you can say that, find an IR, so that go tell your problem, whether he can help or not. It'll be the next step. It's not the first step. The first step has to be that. Yeah.
So that was such a valuable takeaway, Doctor. And thank you so much for sharing your insights and expertise with us, and actually helping us understand the powerful role of the whole interventional radiology. So thank you so much, Doctor, for sharing that
You're
with
welcome.
us today.
Thank you, and the team as well, for the opportunity, because in my own way, we helps people know and some awareness on these things. So the next time, if some patient or some patients attend us, Google about it or try to find something, then I hope that they find or they ask their clinician and their treating physician about IR, if there is a feasibility of IR. That's a success for me, and I think that's a success for the video and for this conversation as well, I feel.
Very true, Doctor. And to our listeners, thank you for tuning into this episode. And remember, if you're a healthcare professional who is eager to delve deeper into medical topics or have questions, do not hesitate to join us on the MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. So until we meet again, stay informed and stay healthy.